Hi, I'm Nicole Clement, a program specialist with the Technical Assistance and Services Center, or TASC, a program of the National Rural Health Resource Center. The first ambulance services in rural areas were set up to do little more than basic cares, and payment was based on how many miles a person was transported, not on the care that was given. Even with the onset of modern EMS with the Emergency Medical Services Systems Act of 1973, which ushered in a more standardized system of care and training, this payment methodology would be the basis of EMS payment even today. Thousands of independent EMS services means a lack of consistency, not only among ambulance agencies, but also between states. As I said previously, EMS has a transportation-based reimbursement system that is dependent on volume. Think about what we know about rural areas. Less people over larger landmass, right? Literally more cows than people in some places. A system dependent on patient volume creates a naturally occurring struggle in rural areas. Consider this. From 1999 to 2004, the age-adjusted death rates for transportation-related unintentional injuries were about 50% higher in rural areas than urban areas. There are several factors that play into that, but one of them is the geographic distance and travel time. Larger areas mean slower response times. EMS providers in rural areas are generally volunteers, not likely paid at all, and if they are, it might not be much. Because of this, these may be basic life support units, or BLS, rather than advanced life support units, or ALS, and generally don't train to advanced provider skill levels as it is costly to do so. And maintaining that higher level of certification would be a struggle. EMS struggles for attention and resources, and a misunderstanding between community expectation versus what EMS can realistically provide is extremely common. Many people have no idea what level of emergency response is offered in their area, but expect providers with top-level training and a high-tech, top-of-the-line ambulance with all the bells and whistles, right? Unless the ambulance service educates the community about what they can provide and the cost involved with the different options, the community will continue to have those misconceptions and the ambulance agency will continue to struggle. EMS is a critical extension of the healthcare team, providing pre-hospital care, working with hospital emergency departments or EDs, serving as part of trauma and transfer teams, and as part of care coordination and follow-up. The last three bullets are definite progress from EMS of the past. As roles and responsibilities for EMS providers are continuing to evolve, state flex programs need to be aware of those changes in order to plan, engage, and communicate the impact with rural communities and hospitals. These things provide opportunities for EMS to find a different place for themselves in the changing healthcare system. I'm guessing most have heard these phrases in reference to what's happening in healthcare. In our organization, we commonly use these phrases when talking about healthcare reimbursement moving from payment based on the number of services or procedures provided to a system that recognizes the quality of care provided. Healthcare providers, including those in rural areas, are developing population health strategies that involve building partnerships and systems to ensure that they meet the goals set forth by the Centers for Medicare and Medicaid Services, or CMS, of better care, healthier people and communities, and smarter spending. But what does that look like for EMS? Well, for EMS, it means moving from emergency-only activity paid by patient fees or insurance and subsidies or contributions for emergency response to emergency response plus wellness, prevention, and other patient care activities supported by alternate sources of funding. Population health is an opportunity for EMS and isn't something that hospitals, clinics, or any providers can do by themselves. It will take a collaborative effort of all of these and more to affect the health of populations. This transitional time in the healthcare system presents opportunities for EMS to find new roles for themselves in the healthcare system, to find reimbursement opportunities that go beyond patient transfer. Community paramedicine is an example of that, where the goal is to not transfer the patient unless it's really necessary. Hospitals and EMS both benefit from finding ways to work together, even more now than in the past. Hospitals need to be providing quality patient outcomes for reimbursement, and partnerships with an integrated EMS can only help. This is a great talking point for flex coordinators. Moving into the opportunities for rural EMS, we've been talking about how hospitals and EMS can collaborate to develop strategies to bridge the gap between current and future payment systems. EMS agencies can also work together to maximize efficiency and share volume and needed resources, not necessarily by merging organizations, although there are situations where that may make sense, but by finding ways to work smarter together. As we've been discussing, population health absolutely is an opportunity for EMS to find a new place. Work with your state office of rural health to be aware of activities in your state, leverage flex and SHIP funding, and ensure that rural EMS is involved and at the table. Another potential opportunity for EMS is emergency triage, treat, and transport, or ET3. CMS has an innovation center, which I'll refer to as CMMI. CMMI has a voluntary 5-year test payment model called ET3 to allow greater flexibility to ambulance care teams to address the emergency healthcare needs of Medicare beneficiaries following a 911 call. The intent of the model is to provide person-centered care, the right care at the right time and place, to increase efficiency in the EMS system. While this is a great way of seeing how we might do things differently pre-hospital and how that could affect overuse in the ED, this pilot payment model is a potentially significant shift at the federal level in how EMS has been thought of and reimbursed for a very long time, which has been as a supplier of transportation. It is similar to the flexibility that EMS providers have from CMS right now during the COVID public health emergency. These are the options being provided through the model. The ambulance provider could transport the patient to an alternative destination, such as their primary care physician's office or an urgent care clinic, or they could provide care in place using telehealth and be reimbursed. Remember, the way the current system works is that the ambulance service gets paid when they transfer a patient to a hospital. Even with these options, the patient will always have the choice of being transported to the ED if that is their preference. Originally, there were 2 sets of funding to be provided through the model. Ambulance suppliers and providers who have already been selected and started their projects as of January 1st, 2021. Standard intervention when a 911 call is received would be to initiate ambulance service, which then either does or does not transport to the ED. ET3 offers other options: transport to an alternative destination or treatment in place, either on site or via telehealth. The second set of funding, 911 triage lines for low acuity calls, was intended to promote successful ET3 implementation, but has been canceled because they did not receive enough applications for the funding for CMMI to adequately determine if the initiative would meet its goal of maintaining or improving quality of care for Medicare beneficiaries and reduced Medicare program spending. Here are a few links if you're interested in more information about ET3. The first 2 are from CMMI and include webinar recordings, frequently asked questions, and such. The third is a map that we at Task had created that shows counties with rural and super rural designations that have ET3 participation. The Federal Office of Rural Health Policy, or FORHP, has placed an increased focus on the rural EMS program area. For the past couple of years, there has been supplemental funding provided to state flex programs, additional to the funding already included in the primary flex program funding. In fiscal year 2018, 37 state flex programs opted in to receive additional funds for a single year to support in-depth technical assistance to rural EMS systems. Projects varied based on identified need within each state. Examples include a telestroke pilot project in Alaska, an interagency transfer project between critical access hospitals and EMS in Idaho, and implementation of mechanisms to better enable quality reporting for rural ambulance services in both Utah and Florida. Fiscal year 2019 also saw additional funding from F4HP for rural EMS improvement, this time on a larger scale. 3-year funding was awarded through a competitive grant opportunity only open to the 45 state flex programs to implement larger projects to build an evidence base for sustainable models of rural EMS care or projects related to data collection and reporting of rural relevant EMS quality measures. 8 awards were made, and those projects are in their 3rd and final year. Rural EMS improvement in the Flex program focuses on operational and quality improvement. A few common examples of initiatives that Flex programs typically fund include technical assistance training and education in mental health first aid, stop the bleed, leadership training, and billing and coding. Meetings and conferences. Meetings could include convening ambulance service providers regionally to share and learn from each other, or gathering stakeholders to discuss needs and potential solutions. Some states are using assessments such as the attributes of a successful rural ambulance service, which helps assess operational status of a service, or our Rural Community Ambulance Agency Toolkit self-assessment, which gauges a service's readiness for the transition to value-based payment. These assessments help Flex programs gather baseline information about the status of services and then identify technical assistance needs for consideration in their action planning. Community paramedicine, trauma designation, data reporting and quality improvement, and time-critical diagnosis activities are also very common. It's important to note that other activities, as they meet an identified need in your state and fit within the goals and objectives of the Flex program, are also encouraged. Definitely have a conversation with your Flex program project officer should you have questions about their fit. You can view detailed activities of any Flex program by checking out the state Flex profiles on the task website. Moving into some resources for rural EMS. The first one, moving from loaded miles to value-based models. As a result of a stakeholder summit held in 2019, we released this guide. We gathered rural hospital leaders, rural EMS providers, State Office of EMS leaders, state Flex programs, a representative from the National Association of EMTs, and the Flex monitoring team. The purpose was to discuss the challenges and opportunities for critical access hospitals and rural EMS providers to better collaborate as they move into new roles in the changing healthcare system. The guide consists of a list of key strategies for rural ambulance services and hospitals to consider working on together that would benefit them both in this transition. It provides ideas for collaboration and potential strategies to better prepare and integrate into the new value-based environment. It also includes suggestions for state Flex programs on ways that they have and could support rural EMS. Continuing on the transformation train, it may be especially important for rural ambulance agencies to embrace transformation to continue to provide access to care in rural areas. To accomplish this transformation, rural EMS agencies must develop new core competencies. We base the toolkit structure on our Critical Access Hospital Blueprint for Performance Excellence, which is based on the Baldrige Excellence Framework, and adapted it to rural ambulance services. The toolkit provides an ambulance agency self-assessment. When taken, results provided include suggestions on which collections of tools and resources they should consider focusing on to assist them to succeed with moving from volume to value in their agency's culture and operations. The collections listed and linked above are available regardless of having taken the self-assessment or not, but taking the assessment provides an awareness of an ambulance agency's current status. Once the self-assessment is submitted, an emailed response is provided with suggested resources based on their responses to provide them some direction. As we've discussed, rural ambulance services for many years have been staffed largely by volunteers. This just isn't sustainable. This guide is designed to assist rural communities in navigating a change from unsustainable volunteer EMS and ambulance service models to those that are sustainable. This guide is intended to direct community leaders through change based on a stepped process that has been used in rural communities throughout the United States. It also includes information on how to assess if a community has an EMS problem, the needed ingredients to change, and a 6-step process to implement change to a more sustainable model of rural EMS. Integration of systems can increase efficiencies, improve effectiveness, and ensure system capacity. The Rural EMS Integration Guide is a practical guide for ambulance services to use in their pursuit of sustaining effective and efficient delivery of patient care and developing into integrated systems with other agencies. It provides experienced insights from agencies to promote integration to the benefit of the agencies, the staff, and most importantly, to the patients. It includes specific step-by-step processes in some integration examples, along with how to measure that the processes are creating impact. Next, we released a document titled Community Paramedicine Impact Reference Guide. The document includes links to articles, research papers, and such that describe both the impact that community paramedicine has the potential to have or has been demonstrated to have on patients, healthcare systems, payers, healthcare providers, and organizations, and others. Those considering community paramedicine systems can review results as applicable to their initiative and use the information to inform their implementation. This guide goes through a process to update content annually. With support from the Federal Office of Rural Health Policy, we at TASC convened the Rural Community Paramedicine Summit in early 2021 to assist facilitating the sharing of lessons learned and key strategies related to the implementation and sustainment of CP in rural communities. This document shares the experiences of established CP providers with rural ambulance services and hospitals for preparation of new CP initiatives. The intent is to inform those that strive to improve the health of rural communities, such as flex programs and state offices of rural health, to enable them to consider how they might best support rural CP efforts through their programs. On our website, which is www.ruralcenter.org, we have topic collections. You can see the full list of topics in the center column on the slide. The EMS topic collection is updated regularly. It includes resources intended to help rural EMS adapt and become a more integrated part of the evolving healthcare system. You'll see there is also a COVID-19 collection that you might find useful as well and is also updated often. A few additional resources that I'm not going to go into great detail about. We filmed a couple of videos to highlight the great work and outcomes of some of the FY 2018 Flex Program supplement projects. The first link describes a project from the Florida Flex Program in partnership with their State Office of EMS that focused on getting rural ambulance agencies reporting quality data. One rural agency speaks in the video about how they've come to better understand why reporting data is important, how it has benefited their staff to have access to the data as well. The second link is a video about a county in Iowa that had a failing response system and how they engaged stakeholders and community to address the issues involving 4 ambulance services and how they made change to better function together. A few organizations to be aware of: NOSOR and NSEMSO host a monthly call of rural EMS stakeholders called the Joint Committee on Rural Emergency Care, or the JCREC. The JCREC has a multi-year work plan to foster and support the improvement of emergency care in rural areas. Definitely let me know if you're interested in the JCREC and I'll get you connected to it. NOSOR also offers an EMS Grant Writing Institute from time to time or in your state if you'd like to arrange it with them, and the annual National Rural EMS and Care Conference. Here's my email to let me know if you're interested in the JCREC. And also, please don't hesitate to contact me if you have questions about rural EMS. Thank you.